Alrighty, guys. Last but not least, we're going to do a quick review, lecture review, and kind of quiz prep for E-Stim for pain control, tissue healing, iontophoresis, and biofeedback. So, just give you a little more context from what we talked about in the lecture earlier this week, and this should help you with your quiz and for the final two. So, there it is. Pain control. So when you're thinking pain control, you're thinking very commonly about TENS, which is transcutaneous electrical nerve stimulation. We're using our TENS to modulate pain, typically using the gate control theory of pain. Again, we're trying to activate the non-nociceptive A beta nerve fibers to go head to head with our nociceptive nerve fibers like your A delta and your C fibers, the equivalent of like rubbing the boo-boo, right, or kissing the boo-boo. So we also want to inhibit transmission of those nociceptive signals at the level of the spinal cord before they reach the brain, effectively closing the gate, working off the gate control theory, and also in some cases helping to release the endogenous opioid system. So that's how we're modulating pain, is by introducing a new stimulus to a place that hurts by enacting the A beta fibers or the sensory fibers, non-nociceptive fibers, to go head to head with your nociceptive fibers to lessen the pain at the level of the spinal cord and make it feel better. So that's basically what we're trying to do. Here's our review, right? So we remember that our A beta fibers are our non-painful sensation fibers. These are responsible for detecting things like vibration, stretching, mechanical pressure. These are non-nociceptive. They can become involved in abnormal perception of pain under chronic conditions, but under normally functioning conditions, these A beta fibers are not transmitting pain fibers whatsoever. And then you also have the endogenous opioid system, or you get stimulation of those A delta and C fibers, which will reach to some extent the level of the brain, enact a central nervous system response, or centralize, like we talked about, the pain response, and produce some of these systematic, just reactive forces, reactive responses in terms of what the brain is telling the body to do. So we're going to activate the endogenous opioid system and push out endorphins, similar to what you might get with opioid type drugs, right? So that's how another way we can modulate pain is by enacting the endogenous opioid system for those feel good drugs to be pushed into the system. Here's gate control. Remember this. Your pain severity is determined by the balance of excitatory and inhibitory inputs in the spinal cord. So it's a balance between what we're getting from a non-nociceptive perspective and what the information that's being received from your A delta and C fibers from a nociceptive standpoint. And when the two go to head at that, what's called the inhibitory interneuron, so at the level of the spinal cord where the brain's not involved, that interneuron's going to, for lack of better words, make a determination and say, okay, we have this balance of both excitatory and inhibitory inputs. How much of this are we going to let go through to the brain, and how much are we just going to send a sort of non-calming palliative response in terms of lessening the gate control or the gate theory? We're closing the gate in response to the stimulus that we're getting from both the non-nociceptive and the nociceptive responses. So again, we don't want to necessarily bother the brain with every single stimulus that we consider to be potentially noxious, right? So there's definitely a hierarchy. So to defend against that from overstimulation and over-responsiveness of the brain and centralization of that pain perception, we have the gate control, which is going to tell us if we introduce another sensation, like a rubbing, a tactile, a non-nociceptive sensation, it can limit the amount of nociceptive input that's being delivered to the brain. And just again, thinking about kid falling off the bike and your mom giving you a hug or kissing your boo-boo, that's gate control theory in a nutshell. So that's just a review on that. So conventional TENS, also known as high rate TENS, we saw this in lab. Short duration pulse, 50 to 80 milliseconds, or microseconds rather. High frequency, 100 to 150 pulses per second. So short duration, because we're going to go back to that chart that I love to reference, right? If you're just trying to introduce a sensory response to act upon the gate control theory, all I really need to do is start to stimulate or activate those A beta fibers, those non-nociceptive fibers. And this is what gives me that good feeling of buzzing, tingling, producing a comfortable sensation of the amplitude that's right to just give you that feedback where it's like, all right, it feels like a nice solid buzz, like that, the way we might cue our patient. And then we may have modulation, which again is going to impact the duration, the pulse width, or the on-off time in order to make sure that we don't have accommodation. So this is going to be most effective. The big thing to remember with conventional TENS or high rate TENS is this is most effective while the stimulation is applied, but not so much after we turn the machine off. So it's going to feel good while the machine is on, but once we take the machine away, it's likely that their pain perception will return. Cool thing about the opposite side of this is our low rate TENS, right? So with low rate TENS, we still have a long duration pulse, a longer duration pulse. So it's now within that 100 to 300 microsecond range, but we've decreased our pulse rate or our frequency to only 2 to 10 pulses per second. So it's just like that tapping, tap, tap, tap per second. And we're also trying to find an intensity or an amplitude that's going to deliver a small muscular contraction. I don't want it to be bouncing around all over the place, but I do want to get some kind of stimulation of those motor neurons to some small degree to help stimulate the endogenous opioid system and the production and release of those feel-good hormones. So you're repetitively stimulating in a small way the motor nerves, and that's why we have to take our long duration pulse, right? That's why we have to spread out our pulse duration, because going back to the chart we love, right? Sensory is first, then we got motor, but it takes a little bit longer of a pulse width to be able to excite and reach the action potential for that motor neuron. So it's going to take a little more duration, right? But at a lower frequency. So we're just getting that nice tap, 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 tap. Typically, you're not going to use this for any more than 30 minutes per section. And potentially, a lot of the time, you're going to end up maybe repeating this every 2 hours. So there's another differential here between high rate or conventional TENS and low rate TENS. You're going to kind of dose this thing in half an hour increments, maybe with a couple hours in between, just because you're effectively going to get that opioid release, which should, in theory, give you an effective pain control benefit for maybe 4 to 5 hours even after the stimulation ends. So where TENS is pretty much done and over with by the time you shut the machine off, low rate TENS gives you the benefit of having potentially, due to that opioid release, a longer lasting pain controlling benefit. And the other part of this is you're going to dose this in 30-minute intervals. With TENS or conventional TENS, you can pretty much use that at your leisure, right? You can't really overdose the TENS. I have people that use the TENS all day, every day, and they're just running through 9-volt batteries like it's nobody's business. So that's the difference between high and low rate TENS, and here you go. High rate TENS is working on the sensory neurons with no muscular contraction. So when you turn the machine on, you're saying, okay, I want you to let me know when you first start to feel the stim, that buzzy, tingly sensation. Okay, cool. You feel it? I want to turn it up until it feels like a firm but still comfortable buzzing sensation without any muscular contraction whatsoever, right? And you also want to be aware that you may use this high rate TENS in an acute situation. It's probably going to be more acutely oriented. So somebody just sprained their ankle, I may use a high rate TENS because there is no muscular contraction, so we're not running the risk of damaging any tissues. So a recent injury with, let's just say, active inflammation. Low rate TENS is going to be a longer duration of pain control. It's going to give you that 4 to 5 hours potentially of the endogenous opioid release. And you're going to have to enact a muscular contraction or reach the threshold of that motor neuron or reach the action potential of that motor neuron to get a small scale muscular contraction to work on the level of the motor neuron. And this is going to benefit the patient because by reaching that action potential, you're going to have increased centralization to some degree of that perception of sensory input and muscular input. And so there will be an endogenous opioid response, which gives you a longer lasting, theoretically, longer lasting treatment time in terms of pain control. So burst mode on the TENS is the stimulation that you're getting for each pulse is delivered in bursts or packages, right? So it's the same mechanism as low rate TENS, and it might be more effective because you're delivering more current, but you're bursting in small packages of various, sometimes varying levels of stimulation. So that's the B that you see on burst mode 10s. You're effectively just changing the little setting on your tens unit to say there's B burst, N normal, and then M modulated. And for the most part, burst mode 10s can give you a little bit more of current delivery, but also it will help to defend against your accommodation. So it will change and manipulate the impulses, the bursts, in a way that will help to keep the nerve on its toes, right? So you're not as apt to accommodate to this stimulation over time. So here you go. This is it in a nutshell. You're going to end up with here's your intensity of intensity and polarity. We've got a biphasic wavelength. It goes back and forth, back and forth, back and forth at a high rate, right? So this is the number of pulses per second. Let's just say this is 1 second. That's the normal standard. We see that we have a lot of pulses per each individual second, or each individual second. So with high rate 10s, again, we said the magic number is about between 50 to 80 pulses per second. So you got a lot of pulses in a small time frame, whereas low rate is a lesser pulse per second, but a longer duration. So you can see here, this wave, this pulse duration or pulse width is very small, but we got a lot of them over time. This pulse duration or pulse width is a little bit wider, right? But we have fewer of them over time. So that's what it looks like conventionally when you're comparing the two. And then burst mode 10s is giving you a little bit of an interburst interval where, like we said before, those bursts are delivered in the same way, but you're providing them in sort of these little packages, right? So now you've taken effectively a packaging of burst of pulses of wavelengths. You put them in a small little package, and then you're delivering them in that package format over time, and that helps to potentially defend against accommodation. That's the big thing to use there. So know those for your quiz for sure. And then electroacupuncture is like Frankenstein feels like, but it's just another way of deriving muscular stimulation through the use of acupuncture needles. So this won't be huge on your quiz, but you may well see this if you go to a clinic that has dry needling, where the PT is certified to do dry needling. So for stimulated muscle contractions, again, rule of thumb here is if you're going through acute pain, or you have acute onset pain, you're primarily going to want to work off the sensory sensations. So this is like post-op pain, and it can help to reduce your analgesic medication input. So with acute pain, you're thinking mostly conventional TENS, because conventional TENS is going to work off those A beta fibers, right? It's more sensory oriented. When you move into chronic pain, let's just say you're weeks out from an injury, you're going to try and enact some motor sensation, twitch contractions. Now you're running into the world of low rate 10s to produce that endogenous opioid effect. And this can be useful in non-surgical management of like chronic pain conditions like arthritis. This says knee, but it could be anything. Osteoarthritis, rheumatoid arthritis, some kind of continuous chronic pain. And the reason we're going to use that is because with chronic pain, we've moved out of the acute phase. I'm going to get mild motor activation, so I'm not running the risk of really damaging anything. And I may be able to alter, like what we see with like H-wave, alter the patient's perception of pain over time and lessen their reliance on long-term NSAIDs or pain controllers like your Tylenol, or hopefully they're not using opioids at this point, but it can help to get those patients off meds, hopefully. There's your contraindication precautions. We've talked about these in the last 3 lectures. You guys should know these by now. The one caveat is we're not going to use motor level electrical stim when muscular contraction might disrupt or delay healing. So if I've got a muscle tendon repair or tear, or I have a surgical intervention that's fresh, that's acute, that we're trying to maintain the integrity of that surgery, let's just say there's sutures or something like this, stitches, I don't want to fire that muscle and potentially ruin the integrity or the success of that surgery until that tissue is properly healed, at which point then I can think about starting to add in some motor level electrical stim. So, yep, parameters, all about parameters. Go back to your chart. I gave you guys that nifty little chart. Look at that and own that. We see the difference here between conventional high rate tens in terms of frequency, duration, amplitude. Please just look at that chart. It's going to be important for your quiz. It's going to be important for your final. It's these charts I think are the best way to digest all this information because it's very succinctly placed all in one nice document where you can compare and contrast each one. So do that for your pain control, do that for your NMAS too. So there's your interferential, and we remember that interferential is going to be a quadrupolar setup where we're going to have sort of this X-shaped electrode placement where we're driving one current, one circuit in one direction and crossing over another circuit in another direction to create at a difference of usually of like a 100 hertz difference to create a treatment area or almost a new circuit within the two, which is the culmination of circuits 1 and 2, and that helps to penetrate more deeply. So here it is. We've got two separate sinusoidal currents that are delivered at the same time, but with different frequencies, usually a carrier frequency of 100 pulses per second. So that's a lot of pulses per second, right? So the current differences produce that clover-shaped frequency in the middle, which we call the beat frequency, within the tissues where the streams are crossed. So there's your Ghostbusters. So you have beat frequency when you have two sine waves that are interacting at different frequencies, and that is what this clover this is your beat frequency, this clover area. All right, so it's the culmination of the two being brought together. And so that helps us to penetrate more deeply. You have to be very aware of where you're placing your electrodes with this. So they have to cross in the channel or else you won't get the treatment benefit that you need. And this helps to at least have a deeper application of your pain control. The other thing is you have lower skin resistance with this, tends to be more comfortable. The penetration, as we've said, tends to be a little more significant. But the cool thing about IFC is that it's good for use on large body parts. So because of the quadrupolar setup, I'm usually going to use this on a back. I may use this on a quad or a hamstring, but this is going to be ideal for larger surface areas of the body where we want to affect a large degree of tissue or a large area of tissue. So when you're thinking like a large scale pain control modality, potentially with some edema control settings, you're thinking quadrupolar setup potentially with IFC just because it tends to be very comfortable. Lower skin resistance gets deeper so we can push through those big tissues and it covers a larger area. So like we said, we've got these two biphasic alternating waveforms delivered through two channels in an X, right? In the middle, we have that clover leaf of the beat frequency. There's a burst frequency. So you have a higher amplitude and bursts from higher to lower frequencies called the burst frequency. Don't worry too much about that. This just makes it comfortable for the patient. The primary thing that you want to remember with IFC is this is for pain control, but you can also increase circulation, sometimes muscle stimulation, but not as effective. I mean, typically if you're thinking muscle stim, you're thinking Russian, right? But definitely for pain control and definitely to increase to some degree circulation. So sometimes I'll use IFC on a swollen ankle just to try and help to push some of that swelling out of the area. And again, you have this intersection. The resultant amplitude occurs halfway between the two lines where they cross, and that's creating a four-leafed clover-shaped treatment field that is responding within that beat frequency. So this is what it looks like for the most part. You've got this clover-shaped field. One thing that you will have as a setting on your IFC for the most part is going to be this sort of vector scan, which is just effectively going to broaden your treatment area. So here's the clover leaf when you're doing a static delivery, right? You'll have a parameter on your IFC, usually on most machines, that say vector scan, and that's when you need to increase the size of the treatment field. So you already get a pretty good size treatment field, and this clover leaf is going to be able to deliver a decent impact to a large area of treatment. But if I need to even broaden that out, I'm going to use vector or scan. Vector scan, you'll see it sort of dictated different ways. And this is going to create a circular energy field of varying amplitudes from this channel field. So now I've got this normal clover leaf and a static setup. If I use a vector scan now, I'm broadening out the reach of each of those potential circuits so I can get a little more coverage. So just knowing that vector scan is something that you'll have as an option you can use for your IFC. So IFC is going to be your modulation of current that's occurring at the tissue level, which is good. And pre-mod is just a similar thing, but just using a single channel. So instead of using 4, we're using 2. And typically, the reason we're going to have this differential is because not all areas are going to be prime candidates for IFC. As we've said, this is sort of primed or more advantageous to larger body parts, where if I'm trying to just maybe work on an ankle or a calf or a forearm, something that's a little bit smaller, pre-mod may be the way to go in terms of getting the same delivery, which is nice. And it just may be more realistic as a treatment modality for a smaller body part. So modulation with IFC, right? We've said that modulating the components of the wavelength can help to defend against accommodation. That's what we're really trying to go for with modulation. So there's a sweep, what's called sweep. It's another thing you'll see on IFC that is going to alter the frequency of one channel relative to the other. So as one ebbs, the other flows, and all it's doing is impacting the wavelength and delivery in a way that is changing it enough to keep the nerve guessing. And again, modulation, you think modulation, you're thinking about defense against accommodation. Okay, so we've got pain control there. Electrical currents for soft tissue healing. So we already know some things that we can use for soft tissue healing. We've got definitely our pulsed ultrasound, right? We're thinking pulse duty cycle 50 to 20%, non-thermal, helping to just send that pulsed wave into the tissue to create, or to enact fibroblast activity, help disperse inflammation, promote proliferation by stimulating white blood cells and things like this. So pulsed ultrasound is good for that. E-Stim can be used too. So we've got high volt pulse current. That's a monophasic direct current. So what we're going to be working with, we'll talk about this in a second, but we can use electrical stim to help with tissue repair. And when you think about tissue repair, you always want to think about high volt. So know that for your quiz. Tissue healing, right? So how does this work? We're going to stimulate angiogenesis, which is just the reconstruction or genesis of blood vessels in the body, epithelial migration and reduction of bacterial activity, and modulation of pain, increasing oxygen perfusion and tensile strength. So essentially what we're trying to do is, to some degree, we're getting just by the nature of having the electrical stimulation, we're helping to stimulate the tissue in a way that will enact healing properties, bring more feel-good, not necessarily opioids or anything like that, but bring those healing tissues, the appropriate blood plasma, things like this to the area, stimulate the tissue by sort of introducing the electrical stimulator and helping to some degree to input enough stimulus to say, hey, to the brain, we got a problem here and we need to enact healing, right? So we're bringing awareness, is what I'm trying to say. We're bringing awareness to that area where the brain can respond appropriately. You also have galvanotaxis, which is we talked a little bit about this before, when you have that monopolar setup and you have that direct current setup and you have polarization. So what we said is if you have movement, you'll have movement in response to the electrical field. So if you need to attract certain things to the area, for instance, I think we used polarization as an example of pushing fluid previously in the other lectures. So if a lot of that blood plasma and those let's just say in the example of edema, right? What we want to do with edema in some of these situations is actually have the same polarity as the edema, because those polarities will repel each other, right? So if I'm trying to push edema from an area, I'm trying to introduce an ionization of the same charge. So when they go to head to head, it will repel those stagnant edema components, right? And push it back into other places in the body, hopefully to get reabsorbed. With tissue healing and gallivantaxis, what I'm trying to do is attract feel good healing proteins and some of these cellular materials to that area in response to the electrical field. So what I would likely do is if my feel good healing proteins, the ones that I normally would be pushing out of the area, are negatively charged, instead of trying to repel them with a concurrent negatively charged input, I'm going to put that as a positively charged input so I can draw and pull some of those healing proteins to the area to assist in tissue healing. So that's what you're thinking with high vault for sure. Wound healing, again, application, you're going to go ahead and you're going to use different applications for different things. So you're always going to produce this at sensory intensity, which when we have, just to make the distinction, when I say sensory intensity, I'm talking about when I'm turning the machine on, I'm just turning the machine up to a place where they feel that buzzy, tingly input, right? The alternative to that would be motor intensity, where I'm actually trying to introduce a muscular contraction, visible muscular contraction of some kind. So when you see sensory intensity, it's about the patient's perception of feeling the buzzy tinglies. If I say motor intensity, it's about the patient's perception and visible contraction. So with HV or high vault, you're going to have a negative electrode in order to promote healing of inflamed or infected wounds in the first stage. And then you're going to have a positive electrode to promote healing of wounds without inflammation. This is typically in the second stage, right? So what I want to do is use different electrodes for different treatment things at different stages in healing, different treatment goals for different stages in healing. So there's your pulse duration. This is typically a preset. I mean, just so you know on your chart, you're going to be living at 40 to 100 a pulse duration in terms of how long that pulse is. So nothing really crazy there. But your frequency is going to be about 100 to 150 pulses per second. And it's going to be a longer treatment time, right? Because we're looking at wound healing. So we need to let that treatment run for a while. So it's going to be 45 to 60 minutes typically, right? Oh, there's a gross one. So yeah, you're going to put it on either side of the wound so that when you deliver that treatment, the electrical current or the ionization or whatever specific parameters you're trying to work on is going to cross through the wound. So you're going to end up with treatments on either side, right? The electrode placement will be either side of the wound itself. Okay, Ionto. We didn't get a chance to really look at this in lab. I'm going to bring this to you guys next week because we'll have a lot of time in lab to go over stuff because we're just going to do compression and lymphatics. So this is a good one to bring around, but just to review, Ionto is traditionally performed in a continuous direct electrical current to drive ions into the body tissues. So it allows for the unidirectional or unilateral flow of ions. So we're going to use like charges to push medication through the skin. And this is going to depend on the ionization on the medicine that we're using. So for example, make sure I don't get this wrong. I don't want to tell you guys wrong. Yes, best of my memory, right? Just to not confuse you guys. So if I'm talking about two major ones that we discussed in class, it's dexamethasone, which is a corticosteroid, and lidocaine, which is an analgesic, right? So dexamethasone is going to be negatively ionized, right? Holds a negative charge. So what I need to do is introduce through my machine, my iontophoresis, a negative charge to repel those negative ions and push that medication into the skin, right? If I'm using something like a lidocaine, which is positively ionized, I need to put the positive channel or the anode directly onto that patch so that when those two go head to head, I'm repelling the positive ions into the skin. So it's going to vary depending on the ionization of the medicine that I'm trying to push into the skin, and I'm going to have to attach a same polarized electrode in order to push that medication into the skin. So if my medication is positive, I need a positive electrode. If my medication is negative, I need a negative electrode. and the amplitude for this current is super low, 1 to 5 milliamps, excuse me. So it really is allowing for improved tissue penetration. And we're using a low current because if I turn it up too high, it gets very uncomfortable to the patient. And I'm not really trying to stimulate anything. I'm just trying to work at the level of that ionization to gradually push that medication in transdermally by repelling the ions of the medication in through the skin from the patch. Okay, so it's nice because it's non-invasive, right? We have a lot of the benefits that we talked about. It tends to be better than topical application because a lot of the time your topical application just can wipe off. You can be sweaty. It can just live on the skin. It doesn't have as deep of a penetration. The best reason that we're going to use iontophoresis for sure typically is to control inflammation for the most part, or can be also used to control pain and wound healing, scar tissue modification. There's a lot, but you're going to usually see it for inflammation or pain control. Those are the big ones. And the nice thing is with iontophoresis, you're not getting into a place where you have to enact a systemic response like you would if you use like a steroid dose pack. So it's nice because we can direct the treatment right over the area that we need the anti-inflammatory property, right? So I don't have to take anti-inflammatory drugs that are going to be insidious through the whole body. I can go ahead and just direct my treatment right where I want it, which is awesome. And the other part of it too is, for the most part, you can get this this controlled rate of delivery that's going to be really, really effective in just isolating the treatment area. You can put it over specific spots. So I think those are the two big ones. And because you're so directed, the nice thing is you have that drug concentration and you can be kept at an effective rate for a longer period of time. So in general, you get better delivery, you get localization, you can stay off the drugs, and you can impact at a higher effective rate over a longer period of time. The other part of it too is it's non-invasive, right? So what do they tell you in ortho? If you have let's just say some orthopedic condition or musculoskeletal condition that has an inflammatory component, the next thing they're probably going to want to do is stick a big old needle in you, right? For most people, that's a tough proposition. So iontophoresis is a nice first line of defense to see if you're going to have benefit from, like, let's just say like a corticosteroid, right? Rather than just going straight to the needle. So that's usually more friendly for the patient. So typically we call this electrostatic repulsion of charges, and that's basically what leads to it's that concept of repelling like ions into the skin. So it's going to repulse things of ionizations of like charges are going to push away from one another. So you've got the red lead, which is always going to be your positive, for the most part, positive anode. And then you've got a black lead, just like on your car battery, that's going to be a negative cathode. Okay. So which one you choose is going to depend on the ionization of the drug. Let's go over this one more time. So dexamethasone it goes on a negative electrode because dexamethasone is negatively charged. Lidocaine is going to go on a positive electrode because lidocaine is positively charged, right? Then you attach that negative or positive, and then you're going to place the other one, the ground or the dispersive electrode, away from the treatment area. So the positively charged or like charged electrode is going to be configured based on the medication you're providing. Its job is to repel that medication into the skin, right? And then the opposite electrode's job is to reabsorb the electrical current. And we have a good picture of that coming up here. There it is right there. So we're using here's our positively ionized drug. So in this example, we're going to consider this to be lidocaine, right? This is we'll imagine this is our lidocaine right here, the lidocaine ions. So what's going to happen is I want to repel those ions into the skin. Lidocaine is positively charged, so I hook my positively charged anode to that area. And then it's going to, once I fire up that small milliamp current, it's going to push the current down, repel by creating a magnetic field, repel that medication into the skin for dispersal. And then my oppositely charged electrode is going to be there just to reabsorb that electrical current. Okay, so this is sort of the circuit in which this is all going to work. So that's what you're looking at doing. That's the conceptually, that's what happens with iontophoresis. Good. So inflammations, there's a lot. Inflammation, or indications rather, there's a lot. Inflammation, analgesia, muscle spasm that can be helped with lidocaine, ischemia. So you can use different medications for iontophoresis. Again, the most common are dexameth and lidocaine, but there are any number of medications you can use. The same holds true, right? You just have to be able to attach the appropriate electrode depending on the ionization of the medicine to make sure that you're pushing it into the skin, repelling it down into the skin. So it can be used for a lot of good things with different medications, but dexameth and lidocaine, those are the big ones for sure. Contraindications, right? You don't really want to do this on compromised skin. Obviously, like anything else, if they don't have skin sensitivity, if they have a sensitivity to the drug that you're going to be putting in, so you have to look at their med history. Because we do have an electrical current, again, pacemakers or implanted devices, that's a no-no. Long-term steroid use over ligaments and tendons. If I have long-term steroid use, I don't want to necessarily add more steroids to ligaments or tendons, because prolonged steroid use at the level of the ligament and the tendon can actually result in soft tissue breakdown or connective tissue breakdown. And you don't really want to use this in conjunction with anything else, right? So this is sort of a standalone activity. You don't want to do Ionto and then add some thermal agent like an ultrasound or cryotherapy. You really just want to leave this be, because you're dealing with ionization, contrast, and medication. Not only that, I will say this as a catch-all too. When I'm treating people, I tend to, and I found that it's going to be appropriate for them. A lot of the times I don't try and mix and match too many different modalities at the same time, because if I do that, how am I going to know what worked and what didn't work, right? So if I'm feeling as though I've got my indication from my PT, they say it's cool, go ahead and try some of these things, I don't want to throw, not that you would, again, in this situation, but as an example, I don't want to throw Ionto, cold pack, and ultrasound at that patient all in one treatment, because if they feel better, I don't know what made them better, right? If they feel worse, I don't know what made them worse. But if I isolate it at the beginning and just have one at a time, right? So then I just do ultrasound and they come back the next visit and they say, oh, I feel great. For me, that's like, okay, cool. We know the ultrasound works. If I just do iontophoresis and they have a terrible response, I know it was the Ionto that caused it. And then the last part of this, EMG, right? So I think you guys sort of understand this. It's a pretty basic construct. Not necessarily, I think EMG is electromyography, so that you're thinking about that when they stick the needles in and they measure the nerve conductancy. This, we're using a form of electromyography as a biofeedback tool. So you're trying to bring certain events at the level of the muscle into conscious awareness. So this is good for muscle performance, kinesthetic performance, and just general physiological biofeedback. So you're not measuring muscle contraction, right? But you're representing muscle contraction on some kind of visual or auditory scale that's going to give you feedback into the activity happening at that muscle. So you put the electrodes on, and then you're going to change the parameters in terms of their sensitivity to detect either small amounts of muscle activity or large or small amounts of muscular activity or electrical activity is really what we're looking at. So there's some common ones. You guys can see these, nothing fancy there. Typically, these are your big treatments. So with biofeedback, we're usually trying to do two things. And this is the example we used of like the carnival hammer and the bell, right? So either we want to encourage giving visual or auditory feedback, encourage a muscle to relax, or we're trying to encourage it to re-educate itself, for the most part, usually to increase activity, right? So with relaxation, I want to make sure my sensitivity settings are high because I want a high level of feedback, like we said, for your small amounts, right? I want to know that I'm able to reduce the contractivity or the electrical impulse of a muscle that's already highly contracted. So I want to measure that on a very finite scale. Muscle contractions have electrical activity. So if I have a muscle that's already firing, there's going to be already a semi-high level of muscular activity going on. And what you're looking for is a decrease in the feedback, right? So if I have an already contracted muscle, my sensitivity is high, it's pinging here, right? It's showing me a visual feedback or an auditory feedback where it's already pinging colorful lights all the way up to the top. What I'm looking for is either through cueing or some kind of manipulation with this patient. I'm trying to take that from here to eventually nothing, right? So in essence, I'm working to give them enough feedback so they learn how to relax that muscle, right? So I'm pinging high feedback at a very sensitive rate. And what I'm trying to do is just, okay, take some deep breaths. Good. Deep breath in, deep breath out. And what I'd like to see is that feedback reduce. And that's going to be my positive sign. So we're going to use this for 10 to 15 minutes. With re-education, we flip it around, right? So I'm going to use a lower sensitivity setting that's going to give me more feedback about larger events. And the patient is set up for active contraction. So what I'm trying to do, or isometric holds, what I'm trying to do is encourage the patient, cueing, tapping, some kind of feedback where now my feed, let's just say on a visual scale, is very low, right? I'm only lighting up about this much. I talk to my patient like push it, push it, push it, push it, push it. And as the muscular activity increases, the representation of that visual scale, in this case, visual or auditory scale, is going to increase in kind. Right? So the harder they push, the more feedback they're going to get. So an increase in feedback in this setting is a positive sign here. And we're going to do this for maybe 5 to 10 minutes per muscle group. Again, because you have to be able to give some relaxation. You don't want to overpower this muscle. Obviously, the reason we're re-educating is because it's disadvantaged somehow. So you don't want to go too crazy. But that's the differential you're going to get with your biofeedback. Same thing, just like sort of like your stim. There's not necessarily any motor points here, but you can place them parallel to each other, and we're trying to measure the electrical impulses that muscle is capable of producing. So here's your therapeutic effects. Like we talked, we can either turn on a muscle or turn off a muscle. And these are some of the conditions. Again, go to your camera and look at that. Know the charts. We love the charts, especially for your quizzes and tests and as using them as a study guide. So look at those, own those. Outside of that, y'all, I think we've covered all three. I'm thinking about maybe hitting you guys with a formal quiz study guide, but as you study for the quiz and in the longer term study for the final in the next few weeks, hopefully these videos are useful to you to just either refresh your memory or clear up some concepts that weren't super clear the first go round. But anyways, y'all, there's going to be more content coming to you guys, so keep a lookout for that, and hopefully you guys enjoy the rest of your weekend. All right, take it easy.